those who stuck around and those who are here to attend. I'm going to discuss dilated cardiomyopathy in the Doberman. We'll start with just sort of background introduction, how we diagnose this condition, and then I will be discussing the research that I've done personally, looking at some of the advanced imaging that I've done with cardiac MRI, biomarker discovery, and then we'll talk a little bit about the longitudinal genetics that we've done that many of you have contributed to and participated in over the last decade, so I'm happy to present that. So, dilated cardiomyopathy is a phenotype, right? It looks a certain way when we do an echocardiogram. We see a dilated heart that has an inability to contract effectively, but it has many etiologies, right? What we are typically focused on when we talk about the Dobermans is this inheritable genetic form. But Dobermans, like any breed, can get a phenotype secondary to other things. So we have to keep those all in mind. We've had diet-associated conditions pop up. Dogs can get myocarditis, so infections of the heart. We are in an area where Chagas disease is endemic, and that plagues a lot of cardiologists in Texas. I was a cardiologist in Texas for 5 years. I have faced this down many times and said, no, your dog doesn't have a genetic condition, it's something else. So we often have to rule a lot of those things out. And then there are other conditions that mimic it that we don't typically see in the Doberman, like the arrhythmogenic form of cardiomyopathy, ARVC in boxers, or atrial standstill. So when we think about dilated cardiomyopathy, over on the left, we sort of have this pie chart of what we do as cardiologists and what we diagnose. And the biggest piece of the pie is chronic degenerative valve disease. And some of you have come in for your screenings and you've presented to me your 9, 10-year-old Doberman, and I've said, great news, your dog has mitral regurgitation, but nothing else, because Dobermans also get degenerative valve disease. Fortunately, they don't typically manifest any sort of clinical signs from it. It's not typically life-limiting or causes heart failure. This is more of a problem of our small breed dogs that we see. Dilated cardiomyopathy is sort of this piece of the pie here. It's about 8%. So when holistically as a cardiologist, it's not what I do every day. It's what you think about every day, but it's not actually what I see every day, unless I'm here and then it's all in our minds all the time. So we think of valve disease as being very prevalent in small dogs, and it tapers off as our patients get bigger. And then the opposite is true of the primary cardiomyopathy, so dilated cardiomyopathy. We see a pretty high rise in our large and giant breed dogs, with Dobermans overrepresented in that population. So what is it? Well, it's a primary myocardial disease that results in dilation of the heart. So on the bottom left, we've got 2 explanted hearts, a normal one in the bottom corner, and then we can see a much more dilated heart next to that. And so that's what's happening. And so I think of the disease as not being named particularly well, because it's not until we end up at the end stage of the disease that it actually becomes dilated. What we are focused on, and this image isn't really playing super well, is what we see on the bottom right there. And this is the echocardiogram, and that heart isn't squeezing well. The contractility and function of the heart is affected primarily. But I think if you were to term it, a heart of systolic dysfunction cardiomyopathy doesn't quite work as well, so we have to, we've shortened it down. But the dilation is the end stage repercussions of not being able to effectively move blood forward through the body. So we think of it as a large breed, middle-aged. More males get this than females for all dogs, but recently, and that was probably widely accepted even in Dobermans for quite a while, but I think recently it's been shown that the incidence is probably about the same. So we see it in males a lot, and oftentimes because we're screening them and we're looking for it, but males and females, it's probably about equal. And then there's a whole host of breed-specific type of cardiomyopathies, and we'll focus on Dobermans today, unless anybody needs a refresher on the Welsh Springer Spaniel problems. Yeah, okay, we'll just move on then. So this slide is not intended to be overly confusing, but I want to sort of bring you into my world a little bit. And when I think about dilated cardiomyopathy, because, and we were just having a nice conversation in the hallway about genetics and what are the things that influence the genetics that might cause a dog to have this problem. And when we think about dilated cardiomyopathy, we think about what are the ways that we can influence it to slow the progression or change the outcome of the disease. Can I get an 11-year-old Doberman with this problem to go on and die of something else when they're 15, right? So what is it that impacts that? And so this is all showing that in the middle, we've got this abnormal problem, that the heart isn't able to squeeze effectively. And then that instigates a whole host of responses within the body. So the body is going to inherently do everything it can to conserve perfusion and blood flow and make everything happy. But in order to do that, there has to be a lot of activation from the neurohormonal axis of the body, the sympathetic nervous system, the RAS system, all of these processes, and they actually perpetuate the problem. They can cause it to continue to progress and sometimes rapidly. So we have to address those aspects of the disease as well when we think about dilated cardiomyopathy. And then how do I think about it? And I'm thinking of Doberman specifically. I think of the first phase as, okay, there's a genetic predisposition. Whether we know what genes are causing it or not is irrelevant. We know that there's genetics involved, right? So it's a genetic predisposition, and having the genetics doesn't mean you're going to have the disease, but you have a predisposition for it. And then the phase that we are most commonly looking for this, and why we do so many screening echoes and screening Holters, is we're trying to identify them before there's any overt clinical signs of any problems. And this is where we look for things like arrhythmias. We look for systolic dysfunction, and unfortunately, as a percentage of Dobermans, sudden death, right? And that percentage is variable depending on what you read, but it's anywhere from 1 in 5 to 1 in 4. So anywhere from about 20 to 25% of Dobermans, that's the first and only symptom they will ever have in this preclinical phase. And then we get to the overt phase. So this is now a dog who has symptoms of their heart disease. And Dobermans are interesting, right? Because they can be in heart failure, and as veterinarians, we're often taught the term congestive heart failure, and that's where we get fluid accumulation or fluid retention. But not every Doberman actually develops congestive heart failure. They develop more of a forward heart failure, so they're unable to pump and perfuse their bodies effectively, so they may just have signs like weakness and exercise intolerance. They can collapse, but they're not having shortness of breath or fluid accumulation. Many will eventually develop those things, but not always. So how do we screen for it? Let's talk about the screening process. Well, physical examination is usually normal. Every one of you who's ever come to the echo clinic knows that. I sculpt them and I say, well, that was normal, and you're like, I don't care. Let's keep going. I need the next thing, because yes, maybe we'll hear a murmur, or they can have an arrhythmia, or maybe they're in failure and you can identify that. But typically, they're normal. They're normal dogs. So what are the ways that we can monitor? And so we have to be very diligent, and I think of all the groups I work with and all the people I talk to, Doberman breeders and owners are so good about doing all of the things that we ask you to do, right? You're like, I did the ECG, I did the Holter, I did another Holter, I didn't like that Holter, so I repeated the Holter. So I have 3 Holters. And I'm like, that was unnecessary, but thank you, we have it now. But I think we can talk about Holters for just a little bit. So often, if you're just doing an electrocardiogram, so just laying on the table, hook them up, watch for 5 minutes, it's often normal. But anything abnormal, ventricular, ectopic, abnormal on that ECG does warrant further evaluation with the Holter monitor. And it's been shown that even just 1 or 2 VPCs during that time is predictive of a Holter that is likely to have a lot of ventricular ectopic beats. But nevertheless, it's not really the recommendation for how we screen for this. Instead, we're going to recommend Holter monitoring. And I just put up here sort of what's out there in the literature, and I think every cardiologist needs to think about this individually for every individual dog. It's not so simple as saying less than 50 is normal, so just forget about it. Any amount we should think about, but not necessarily implicate a dog as diseased because of that. Right now, the greater than 300 is considered the cutoff that's being reported. So if a dog has more than 300 in one day, that's likely diagnostic for having an arrhythmogenic form of the dilated cardiomyopathy. Or if you did 2 Holters within a year and they both had more than 50, that would be helpful. Any complexity to the arrhythmia, so looking not just at the single beats, but are there couplets, triplets, runs of ventricular tachycardia? And then recently, the group out of Michigan State looked at the sensitivity of like a 1-day Holter versus up to 7 days. And so what they found was that several dogs would be normal on their first initial 24-hour Holter, but over the subsequent 2, 3, 4, day 5, 6, and 7, more dogs were found to have that threshold, so greater than 300 VPCs. The biggest distinction occurred by day 4. It seems like 5, 6, and 7 didn't really add much more to that. So I have recommended that we do 4-day Holters on Dobermans that I'm worried about. So anytime we get that kind of suspicious one-time Holter, I might say, well, why don't we repeat it in 3 months and do a 4-day one to just really see where we are. And before we move on from that, I do think it's really important that we are all aware too that dilated cardiomyopathy is not the only reason a dog will have this arrhythmia. And I try to advocate always that we do all the other things before we decide that this dog has a problem, because it's really frustrating if a dog has 400 VPCs, they're implicated, they're committed, they have DCM, and then that dog never gets it. And we go, well, that was a bummer. We took it out of breeding, we took it out of everything, and we're worried about this dog. So there is important due diligence that needs to be done whenever you get an abnormal Holter, right? So obviously the echocardiogram needs to be compared with that. And then how old is this dog? Is it a 7-year-old Doberman? Well, guess what? 7-year-old Dobermans get lots of things that can cause VPCs in addition. So full blood work, we always look for infectious diseases. Here would be Chagas, everywhere is ticks. And then we look at things like abdominal ultrasounds. Let's rule out other things that can certainly be causing this. So I always tell my students that if a dog comes to me and this is any dog, not just a Doberman, but if it comes to me for evaluation of ventricular arrhythmias, it's a huge workup. We have to do a lot of things before we say it's the heart, right? You have to rule all of the other things out. So I think that is just yet another level and layer of factors that we have to consider. Radiographs are unhelpful in the screening process because, as we can see by this image at the bottom, the heart itself functionally can have lots of abnormalities. It's not squeezing effectively, but it might not yet have achieved that dilation that's going to show up on an X-ray. And if the dog isn't in heart failure, it's not going to help us. So that's why we're not lugging our X-rays down here to screen, and you're not paying for those because they're not really helpful. They're only helpful at heart failure. So it comes down to the echocardiogram. This is still considered the standard by which we make this diagnosis. We have additional tests like cardiac MRI and things that I think are also very helpful, but probably not yet available mainstream for everybody. So we're really looking at the echocardiogram to try and make the decision about that. So not every owner, not every breeder, and not every dog is going to have access to that availability or the resources to do it. And so we've done quite a bit of work looking at cardiac biomarkers. So are there blood tests that we can do that might raise the level of suspicion or help confirm the diagnosis? And so the first ones that have been looked at are the troponins. So these are looking at injury to the heart muscle. And dilated cardiomyopathy does cause muscle turnover in the heart, replacement of heart muscle with things that are not heart, like fibrous tissue or fat. And so troponin levels can be elevated. Most helpful to us clinically and to you clinically are going to be the stretch markers. So those are the natriuretic peptide, atrial natriuretic peptide, or brain natriuretic peptide, which is the one that we focus on. So the BNP or NT-proBNP, this is secreted by atrial and ventricular myocytes when they're stretched, which is exactly what happens with dilated cardiomyopathy. And then lastly, our group has been looking at a biomarker called galectin-3, and this is a marker of fibrosis. So if there's a lot of fibrosis in the body, this marker is going to start going up. And as heart muscle cells get replaced from dilated cardiomyopathy, they typically get replaced with collagen and fibrous tissue. So galectin-3 is potentially a marker for looking at this disease, and I'll talk a little bit about what we have found. So in terms of the peptides that we look at and we use, the N-terminal proBNP or the NT-proBNP is the most helpful one. And so there have been no less than 4 studies now looking at Dobermans and looking at screening Dobermans to help predict whose echo is likely to be abnormal if the value of based on what the value of the NT-proBNP is. And so the most sensitive number is around 500 picomoles per liter. It's actually 487, I believe, but we just say 500. Let's just call it 500, and that was repeated both by sending blood out to a commercial lab like IDEX. It was also validated by using an in-house benchtop assay. We at our practice use the BioNote. They've been actually at DPCA Nationals once before. I saw them in the exhibit hall. It's just a little one that sits on your tabletop. Little cartridges go in. It's very easy to use, and we validated that and showed that this also works. So if I have an owner who is maybe on the fence, or they don't know, or they've got 14 dogs, and they're like, what 7 am I going to do this year? What 7 can wait? This is a really helpful way of prioritizing who should get the echo this year, who can wait 6 months. Resources are finite for everyone. No one, we don't want to force people to overextend themselves. So this is very, very useful in that regard. Now, an NT-proBNP can be elevated for other reasons. So we do see false positives sometimes. And by making that number 500, it increases the sensitivity. And that's what you want in screening tests. You want things that are really sensitive, because you don't want a dog who has the disease to be missed. But we have to, again, raise that sort of level of terror inside of us internally, because by making it 500, there's going to be 20% of dogs who don't have heart disease. But we're going to put them in the pile of you really need to be evaluated. So if your Doberman gets this test done and it's above 500, it depends on how high above 500. If it's 508, don't panic. It just means get the echo done. Let's go ahead and get it done. This is the worst way to diagnose it, and that's after the fact. So what we're seeing here, and this will kind of go back into a little bit of what we've done with the MRI work, is what happens to the heart and the muscle itself. So in this quadrant of images, the bottom left is what normal heart muscle looks like. It should be parallel, it should be nice and sort of compact, and there's not a whole lot of space in between the heart muscles themselves. And so that allows for that coordinated synchronous contraction. The top right is what we see to the heart muscle in a dog who's affected with dilated cardiomyopathy. So those fibers become known as wavy fibers or attenuated fibers. So they're being stretched out already, and it's hard for them to coordinate that contraction and overlap with each other effectively. And then there's an expansion of things between the heart muscle that isn't muscle, and that makes it hard for the heart to squeeze. So that bottom right is showing us what else is in the heart muscle itself. So it's a cross section. So instead of the heart muscle cells being long, we're looking at them on end, so they're just like little circles. And then the part that looks like white bubbles, that's all fat. And so heart muscle doesn't get fat in it because they eat the wrong food. It gets fat as part of a replacement due to injury. And then the part that's blue, that's sort of coming up from the left and coming up over the top, that's all fibrosis. And fibrosis does nothing good in the heart at all. It is both ineffective at contracting, and it also doesn't conduct the electrical activity of the heart. And this is the substrate for arrhythmias. And when I talk about the MRI research, I actually was able to prove that in Dobermans. So we'll talk about that. So I am one of, if not the only cardiologist who performs cardiac MRIs. I do it in all kinds of dogs, not just Dobermans, but it's the same exact cardiac MRI that a person gets. And so we don't have to get too far into the science behind all of this, but a little bit of background so when I explain the results, they make sense. So the MRI is great because I'm able to image the entire heart, and I can see it in every angle, and every chamber is the size it's supposed to be. I am not limited by the chest. I'm not limited by the ribs. I'm not limited by whether or not the dog wants to lay on the table on that particular day or not. They're not panting, and we're able to see everything. So an echo is really good, but an MRI is perfect, if you will, when it comes to looking at the heart size. Then the other thing that I'm limited by when I do an echo is I can't tell you what is making up that heart muscle that I'm looking at, right? It doesn't change in appearance in terms of dilated cardiomyopathy or not. They look the same. The chamber gets bigger, so the lumen gets bigger, but the muscle looks the same. With an MRI, I can tell if that heart muscle is muscle and fibrosis and fat, inflammation, iron overload, all of the things that make the composite. And that's going to be really important, I think, for the future, because not every Doberman, and I'm going to show you, has the same form of DCM. And not every one of them is going to have probably the same response to treatments because they have different diseases and different risk factors. So we'll talk about that. And in people, it's absolutely the standard, right? Yeah, you get your echo, sure, but then you're going right to the MRI. Once they, if you have HCM, echo MRI, DCM, echo MRI, coronary, echo MRI. Like, you're gonna get that because there's so much information that we need to have. So not only diagnosis, but risk assessment, therapeutic guidelines, and then response to treatments. So what are these features and how do we use them? So I already briefly discussed sort of what we talk about with heart size. So this is just sort of what we see with an MRI. I'm looking at the heart. In the middle is short axis slices through the heart. So I'm looking at the heart at every level. I can see the left ventricle, the right ventricle, everything. That far right image is a 3D reconstruction of that dog's heart. I know what the lumen looks like. I can measure the mass of the heart, the walls, and then the bottom just gives me exactly that, a printout of everything I need to know about that dog's heart from a size perspective. And so I can do this very quickly with an MRI now. It takes me about 8 to 10 minutes to do that, which is pretty fast. It does require anesthesia, but it's still very fast to do it. This is something that has a lot of promise in people with myocardial diseases, but hasn't really been looked at fully in dogs. So that was part of a study that we did. And this is called late gadolinium enhancement. So what does that mean? So hearts can undergo damage and repair and remodeling. And if we think about what people get a lot, so like a myocardial infarction, their coronary artery gets blocked, no blood goes to a portion of the heart, that heart muscle is likely going to die, and then over time it's going to get repaired and replaced with that fibrous tissue again. And so gadolinium is a paramagnetic contrast agent that when you give an injection of it is going to go into the heart itself. So what we see here in this image is we give the gadolinium, it's in the blood because we gave it IV, and then it's going to diffuse into the heart muscle. And if the heart is normal, the capillaries are going to flush all of that gadolinium out. So when you repeat your scan, it'll look normal. But if you have a scar or you have a lot of fibrous tissue, the gadolinium is going to get trapped there. And then when I run another scan, it's hard to see here, but the heart, instead of looking black, you get these bright white spots along the myocardium where the gadolinium has stayed. And in people, having late gadolinium enhancement is a huge risk factor for developing arrhythmias and sudden death. So we wanted to know if that's true in Dobermans. I'll talk about that in a minute. I'm like teasing it, but I haven't totally given it to you yet. I promise, I'll get you there. In addition to late gadolinium enhancement, we can also do what's called mapping of the heart, or a quantification of their extracellular volume. So how much fibrosis, what is the space in between those heart muscles? How bad is that? And this is a little easier to do because it doesn't rely on an area of contrast to be taken up. Because what if Dobermans never had scarring? They didn't develop local scars, but their whole heart developed a lot of fibrosis. How would I detect that? Well, this is how we detect that. So we're looking for that interstitial fibrosis, which again, in people is associated with worse outcomes. So if you have a cardiomyopathy and a lot of fibrosis, you tend to do worse. So they're going to be more aggressive at monitoring, more aggressive at treating, more aggressive about transplants. And we get really pretty pictures. So echo is black and white. MRI is a colorful, like it's just pretty, right? They're pretty pictures. So we can do all of that. And then I said we can calculate it. And the bottom right is an example of what happens to your extracellular volume space. What happens? And each of those little letters are different types of diseases. And you can see that DCM is right in the middle. It's sort of a yellow-green color, and that's because compared with normal, there's more fibrosis. And so in people, they can actually help distinguish athletic hearts from cardiomyopathy hearts by doing MRIs, because they're both going to look big, right? You know this, Dobermans can get big hearts, and sometimes we're like, oh, it's big. It's not abnormal, it's just big. He's a big dog. He's doing a lot of activity. And then lastly is T2 mapping, and this is looking for inflammation. So I think this is where it will be really interesting to have more information on this with Dobermans, especially if they're having arrhythmias. Because what if they have myocardial inflammation due to whatever reason, not cardiomyopathy? They had a virus, there's other infection, there's something else going on. And that's why they're having their arrhythmia, not because of cardiomyopathy, but because of something else. So we can actually quantify and measure if they have any inflammation going on. This is just to prove that we have normal values. We validated this, so we know that we can compare that back to normal. And then lastly, just sort of as in our background before we get too far along, is the genetics of dilated cardiomyopathy. So in people, more than 50 different genetic mutations exist as causes for what they term non-ischemic dilated cardiomyopathy. We don't have that same level of robustness in our population. So we know in Dobermans that it is a genetic disease, but what do we know about just the overall population? It's progressive, and then depending on which paper, from which country, on which day, I think everyone's going to center somewhere around that 50% of Dobermans are going to make up the DCM populations that we see. So 1 out of every 2 dogs that gets diagnosed with DCM at a clinic is probably a Doberman, and they have variable but high lifetime risks compared with a lot of other breeds. Irish Wolfhounds, Great Danes, they also have a pretty high lifetime risk, but they're closer to that 25%. And some Doberman studies, it can be a little bit higher. One report was 60. It's not 60%, but we know that it goes up as they get older. So what are the 2 genetic tests that have been evaluated most in Dobermans? Well, it would be DCM1 and DCM2, so the PDK4 and the Titin mutation associated with the sarcomere. So the idea and what's been reported with PDK4 is that it has incomplete penetrance, meaning that dogs often have this mutation, but they don't go on to develop the disease. And Kate Mears reported about a 37% penetrance. So 1 out of 3 dogs with the mutation are probably at risk, where 2 out of 3 don't end up having that problem. PDK4 is necessary for utilization of fatty acid for heart muscle. Heart muscle likes fatty acid. It makes a lot of ATP. It helps them squeeze really well. So the idea is it's a starved heart. It's deprived of energy, and it's not able to utilize fatty acid. This has not been associated with DCM in any of the European papers, so that doesn't seem to be an issue there. Titin is newer, and there have been very few reports at all about its impact on DCM, other than one thing where Kate reported a 21 times more likely developed DCM than negative dogs. That's not true of the research that we did, but it is still higher for sure, but also an incomplete penetrance. So again, none of these mutations are going to impact the disease the way we would like them to, in that we found something that is 80, 90, 100% penetrant. This is the problem. Let's put all of our eggs into that basket. I don't think we have that basket. So that's my take home from there, but we'll talk a little bit more about that. And then newer research, chromosome 16, they had some association identified, but there are no candidate genes on that chromosome at this time. But chromosome 5 does have 2 that have been reported, and I believe these are now available tests as DCM3 and DCM4. I don't know anything about them in terms of their impact on any North American dogs, but the impact in the European ones was that the RNF207 seems to be important, and I'll talk about that a little bit later on. Okay, so we already kind of touched on what PDK4 does, so I'm going to kind of skip over that just to say that in the early work that Dr. Estrada did, they did skin biopsies of fibroblasts, they cultured it, they grew these cells, and then they measured their energy metabolism. And they found that dogs with the PDK4 mutations, both heterozygous and homozygous, had significant reductions in their ability to utilize oxygen consumption and fatty acids. And then when they kind of looked at it, what was happening in the different dogs, again, they found that there were some decreases, but they ultimately weren't statistically significant in that population. So when we dig further into it and I talk about the longitudinal work, the PDK4 mutation probably doesn't have as much of an impact on the development of DCM in this breed as we once potentially thought it could. So again, UK Dobermans, they're not seeing this. And there was no association with Titin or PDK4 in the European dogs, but their big one, and we can see that over here. I'll point, well, maybe my computer will give me, nope, it's not gonna let me do that. The big take home here is if you look at this mutation here on this, on the RNF207, if we look at the DCM affected dogs, if they're homozygous for this mutation, almost every dog ended up with DCM, and there were just a few dogs who were homozygous and then ultimately didn't develop it. So there was a very strong association with having 2 copies of this mutation and developing the disease. If you have 1 copy, it still looks like about 50-50. If you have no copies, it's 50-50. And they looked at Titin and PDK4, and again, there's no distinction. They never separate out. So that didn't look to be, that doesn't appear to be the same problem in the European breeds. All right, so let's talk a little bit about the results that we have from our Dobermans. This was the MRI study that I've been sort of teasing you about. So this was a prospective study. We included 34 Dobermans total, 24 with preclinical DCM, and that was based on their echocardiogram. So they had to have big hearts. They were all on pemobendin at that time. And then there were 10 healthy controls. Healthy control Dobermans being age appropriate. So they were anywhere from 5 to 9, and they had no abnormalities that we could find, so they got to be considered healthy. And then we did echo and MRI on all of them, and we tried to characterize their tissue as well as their arrhythmia potentials. And so this was helpful. Not that we didn't know this already, but echo underestimates the size of the heart compared to the MRI due to the limitations of the echo, and that the differences between an echo and an MRI got bigger as the hearts themselves got bigger. And the reason that is because with an ultrasound, we're only able to look at one slice, basically, of the heart at a time. And with dilation, it starts to remodel, and it doesn't keep its same shape. It becomes rounder. It doesn't quite have a bullet anymore. It doesn't necessarily expand this way and this way equally. So the assumptions that are made by the echo become worse compared to the MRI. So I don't think MRIs are going to be used to screen for Dobermans, but it's possible, that that's somewhere we go. Looking at the size of the heart, there was a statistical difference based on the mutation that the dogs carried at that time. So the dogs who had the Titin mutation, or DCM2, did have significantly larger hearts, both in diastole and systole, compared to the PDK4 hearts that had the mutation as well. So there seems to be a little bit of a difference. Now again, they're all affected, And they could be at slightly different stages of their disease, but it is something that we observed. But what was potentially more interesting is that it also showed that they had worse function. So they didn't squeeze as well. Their ejection fractions were worse with the Titin mutation than PDK4. And what this bottom image here, this graph is showing, is the size of the ventricle, so how many mils it is, compared to how thick the walls are. So with dilated cardiomyopathy, what happens, or what should happen, is in order for the heart to eccentrically dilate, it actually does retain its mass. In fact, the mass actually goes up. The walls look thinner because the lumen got bigger, but there's actually more muscle there. If you weigh the heart of a Doberman, it weighs more when they have DCM than it did before they have DCM. There is more muscle there. But with the Titin mutation, their muscle doesn't increase. It's sort of a flat line. They just keep getting bigger, and they're not able to replace or add more muscle to that. And the question is, why is that? And there's some theory that when Titin breaks down, so it's what supports the whole sarcomere. So when it breaks down, you get slippage of the muscle, and it's not able to repair itself and get thicker again. It just sort of slips away from that. And then we did actually find late gadolinium enhancement on Dobermans. So that image, again, we want all the muscle to be black. This is an area where the gadolinium has been retained. So these Dobermans in this study, it was 11 of them, so not quite half, did develop focal scarring. And that's not because they have myocardial infarctions, their coronary arteries are obstructed. It's because parts of their heart muscle do in fact die. And so when looking at the repercussions of that, we wanted to see what was the influence of that on their arrhythmias. And it's probably not too surprising. So diffuse fibrosis, and the term for that is ECV, has a minimal impact. There is a positive correlation, but it's like, okay, it's not that great. But if they have late gadolinium enhancement, their Holters definitely told us so. So 91%, almost all of them, who had an enhancement on their MRI had ventricular tachycardia on their ECGs, on their Holters, I should say. And the presence of it, late gadolinium enhancement, was, again, the specificity was 90%. So if I do an MRI on a Doberman and I see that they have late gadolinium enhancement, I don't really care if your Holters have all been okay before that. You're going on something. You are going on something because that's going to be a problem. And you can see, again, it's a huge risk factor to have that. And that's exactly what they see in people. That's exactly what they see. It doesn't appear that PDK4 has any impact on whether or not they had enhancement. So it's not that energy starvation process that's doing it. Oh, sorry. And then there also wasn't any significant association with the Titin mutation. So it's not the genetics that are causing this. And so I don't have an answer for that. So if the question at the end is going to be, well, who gets the enhancement or why do they get scarring? Don't have the answer to that yet, but I'd like to figure it out. And then just the genetics alone, there wasn't an association between ventricular arrhythmias and the PDK4, but there was an association with Titin again. Not as strong of a predictor as having, say, a scar on an MRI, but I would use this information to say that if I have a Doberman who carries one or more copies of the Titin mutation, I'm going to make sure I get their Holters done consistently. We're going to screen them no matter what, but I might screen that dog with Holters twice a year instead of once a year, something like that. And then this is everybody's worst nightmare of a Holter. This was a dog who was just basically in ventricular tachycardia for about 40 minutes. I mean, my heart was like, oh God, how's your dog? How's your dog? That's how it goes. Looking at the human experience, so they do have Titin variants, so mutations in the Titin gene that are associated with DCM phenotypes. And they also found that it is not associated with late gadolinium enhancement. So I didn't see it in Dobermans with this mutation. People don't seem to have it either. But it does appear to increase the complexity of arrhythmias because it's associated with more fibrosis. So good news is I did that test. I decided to look and say, do Dobermans have more fibrosis? The first answer is absolutely they do. So if a Doberman has DCM, you can see that their value of fibrosis is way up here compared to their healthy counterparts. So that alone is a very sensitive way of screening for DCM. So will we ever get to the point where a normal heart on echo is going to have abnormalities on an MRI and we'll be able to screen them sooner? I don't know that yet, but that's the question, and that's the next test. That's the next study. And then we looked at the difference and the effects on the mutations. And if they don't have any genetic mutations, they tended to have the lowest amount of fibrosis. Then PDK4 came up, and then the biggest jump was right here in that Titin mutation again. So just like in people, where Titin variants increase the amount of fibrosis, we see that too in Dobermans. And it also potentially is why they have such a higher incidence of complexity to their Holters and to their arrhythmias. So lots of really interesting, very, very important stuff I think came out of that study. But again, it's 34 Dobermans. I would love to repeat this in 500 of them, but that's another day. All right, so how does this work in practice? So I want to just briefly sort of go through the longitudinal data that we have. So this was prospective longitudinal evaluation of about 800 Dobermans. We started in 2017, and we've just kept going. We stopped collecting genetics on them in 2022, but we have a whole bunch of Dobermans, and they all got echoes and Holters, blood work, and genetic analysis when available. And so, as you would imagine, right, we didn't get all 800 of them in the full process because many of them we lost to follow-up. A lot of them are controls still, and they're really young, so we got to wait. We got to give them some time. I'm not going to include normals for dogs who are less than 7. Once you're above 7 and you're still normal, you're probably going to be okay. Diet was a big problem. We all figured that out at the end, but a lot of these dogs were on weird, funny diets, and many of them are normal now who were abnormal before, so we just said, let's not make this more complicated, so just exclude the diets. Some dogs had one but not both mutations tested, or we got them later. We didn't have Holters on every single dog. They all had them, I just didn't get the information. And then, not surprisingly, a percentage of these dogs had other problems, and those were treated or diagnosed at different times. So what did we find in these dogs? Well, a very large proportion of them had at least one mutation. So these two mutations, PDK4 and Titin, are very prevalent, okay? So having a high prevalence of a genetic mutation isn't necessarily a helpful thing, because then everybody has it, but not everybody gets DCM, so that's not helpful in that regard. So, but we didn't, it wasn't every dog, so there's at least that part to help us. Over the lifespan of this study, we did identify DCM about 3/4 of the time at various time points. They weren't all negative on the first day, like many of them were 5 and normal, and then by 2023, they ended up with DCM at some point. And the median age was about 7. We had a few very young dogs, and then a whole bunch of like really old timers who got it, and you're like, you did fine, you did good, you got to 13. And that our control dogs were difficult, but we had to wait until they were old enough so that we didn't just inadvertently include them. This is that same table that we saw from the UK study looking at the RNF207. And so here's what we see, that the PDK4, especially when it comes to sort of the homozygous and the heterozygous, yes, there are more DCMs in those two populations, but it's not very high. And I like to look at this value the most, the positive predictive value. What is the positive predictive value of having this mutation? 56%. So technically higher than guessing by 6%, but not much. So when the positive predictive value of something is 50%, it's 50-50. So you're like, well, That's not going to help me. I can't do anything with that information. I just have to do everything I always do, which is everything. So not really helpful. So to me, I'm losing faith in how strong of a predictor this mutation is in this breed at predicting who's going to end up with DCM. That's where I sit at this moment. To be determined maybe later. But again, it doesn't mean it's zero, it's just not as high as we think. This is where things get a little more interesting, and this is on the Titan mutation now. And so if we look at the 1 or 2 copies, they're quite a bit higher between the 2 of them. And in this one longitudinal, the positive predictive value was 90%. So most of these dogs over their lifetime did develop DCM and has a high odds ratio and a likelihood ratio, both of which are saying, okay, this is probably a mutation that we should take seriously, and if a dog has it, we need to be vigilant about screening to make sure. That's kind of where I stand. If we look at the Cox proportional hazard, the top line is Titan, the green line is PDK4, and the blue line are sort of, you don't have any genetic mutations at all. And notice that even if you have no genetic mutations, there is an incidence of DCM in this breed. So it's not these 2. There's, who are you? Who are you? Are you a combination? You have to have 2 or 3 mutations? Like, is it just one other one out there? Are there 49 more? Like, who are these dogs as well? But there's a clear risk of having that Titan mutation. And when we look at hazard ratios, 1 means nothing. Like, it's the same. And 1 is between these 2 numbers. So again, PDK4 is showing me that there's probably not a huge risk, whereas when we look at Titan, those numbers are potentially 2 times, I don't think it's 14 times, but it's quite a bit higher. So those dogs are more likely to go on to develop it. So what do we say? Well, I think dogs who have DCM1 and 2, PDK4 or Titan, are at an increased risk, but that greatest risk right now appears to be associated with the Titan mutation over the PDK4. The relative risk is lower in this population than what has been reported, and those were those 2 reports that Kate Mears had put out about the 21 times more likely or 8 times or whatever those numbers were. I don't think we're seeing it to that extent. And that we are currently right now doing the statistical analysis on the combined. So many of these dogs had PDK4 and Titan. They were homozygous for one and heterozygous for that. I mean, like, there's a whole lot of combinations that we have to evaluate as well. So yeah, I think there's an increased risk for Titan in North America, the RNF207 in the UK and European breeds. And will this help us target our therapy, alter our follow-up? Should we screen earlier? Will MRI be influential in all of that? I do have a little bit more in terms of like treatments, but honestly our treatments haven't changed in the last 8 to 10 years. It's still pemobendin and antiarrhythmic support when needed. So I did want to leave a little bit of time, because I know we got in here late, to answer questions regarding any of what I've presented that you want to know about. Yeah?
With the contrast, the gadolinium in humans, I know you have to be concerned with a patient who has kidney disease or kidney dysfunction before you administer that contrast. Would you recommend that the dog is screened for kidney disease before the MRI?
Yes, that's a great question. So gadolinium is cleared by the kidneys, and it can exacerbate kidney function. So in dogs and cats, we use like iris scoring and other methods to evaluate what we believe is their kidney function. I don't think you need to like evaluate GFR and go that far. So the way we use it is, and all of the dogs in these studies have done great. And I've probably done over 500 MRIs now in dogs and cats. And if they are azotemic and they have kidney disease, I just don't do it. That's the way I would approach it. And so most of these dogs wouldn't have that problem because we recommend it early. I don't know that MRI is going to be as helpful in a dog with heart failure because we are limited in what we're going to gain from that information in terms of treating them. So, but yes, it is something we always are aware of. Yeah?
Can you talk more about treatment, or can I ask a treatment?
You can ask a treatment question.
Okay, so a dog that has the TTN, 1 or 2 of them, and has arrhythmias, for starting them on pimobendan if their echoes are normal?
Good question. So the question is about where does pimobendan come in for a Titan dog who has arrhythmias? So at least we can assume, right, that Dobermans from the PROTECT study, that was the landmark study that showed the delay of onset of heart failure in the pimobendan. We can assume that some of those dogs had Titan mutations, right? We can assume some of them had PDK4s, and we can assume some of them had something we don't even know about yet. And if you look at the incidence of arrhythmias, worsening or better, there wasn't any improvement or change by putting them on pimobendan. And those were dogs who had structural changes to their heart. So I can't rationalize a way in which if they were structurally normal but had arrhythmias, that pimobendan would influence that positively or negatively. I just don't know that it would make a difference. The question is, could you initiate pimobendan at a certain time, and would that help delay it even more? That's a very interesting question as well. Like a Titan, homozygous positive Titan dog who had 3,000 VPCs, and everyone's like, this dog is gonna get it. Is there a role in doing something sooner? I don't know the answer to that. I think what I would advocate for, though, differently, is if I had a Titan positive dog who I believe is going to have worse arrhythmias, even without an MRI, and their arrhythmias were complex, I would more likely be treating them with a higher dose, starting dose of antiarrhythmic drug like sotalol, or I would already have the discussion about doing multimodal therapy. So sotalol in addition to adding in something like mexiletine or sort of additional therapies. And we're seeing this in boxers, so we're doing an MRI study in boxers, and their MRIs are showing us that the most difficult to control arrhythmias in boxers are the ones that have the most changes on their MRI as well. So I think we are being more aggressive in some dogs because we know that they're likely to fail just a single standard dose of sotalol. Yeah?
Does the veterinary community ever think about doing prophylactic, like with an ACE inhibitor?
Mm-hmm. Yeah.
I mean, like start the dog at 3, and I'll just use myself. Our family is just all heart.
Uh-huh.
Well, 3 generations, all heart.
Mm-hmm.
And my sister and I have,
Yep.
aortic replacement, and I've been on an ACE inhibitor since I was 30,
Mm-hmm.
for the reason to stop remodeling.
Great.
the heart. What about and I imagine it's fairly safe.
It is fairly safe. So there's not been a study looking at it just prophylactically ahead of time. There's one study that Mike O'Grady did 175 years ago, it feels like now, where he gave benazepril to Dobermans who had the occult form. So they had echo disease. And he was able to show that there was a modest delay in heart failure in those dogs who were put on an ACE inhibitor. But then the PROTECT study came on and just blew that out of the water. So I think what I teach my students and the way I teach the residents is that I typically recommend some modification of the RAS system, either with an ACE inhibitor or spironolactone or both, in Dobermans when they have the disease. But I've never thought about it ahead of time because, again, I don't know how much the RAS system is actually being upregulated or altered. Obviously, there's probably things that are occurring that we can't detect sooner. So I think there's a possibility, but you would likely be treating dogs who don't have the disease who maybe would never get it. So you have to figure out first who's the highest risk population, and then would that make a difference? So I think there's still more to learn there. I think the future of treating the RAS system is we're kind of moving away from ACE inhibitors, and we're moving more to angiotensin receptor blockers and drugs like Entresto. And now that it's generic, it could in fact potentially be affordable for somebody who owns a Doberman. But before, lordy lord. I mean, Entresto for a Yorkie was like $600 a month. You can imagine what it would be for a Doberman. But now, great news, it's $65 a month So I think that's probably going to be a very real thing that's coming to large breed dogs in the near future. And in people, it is a game changer with dilated cardiomyopathy. So that's something in the future to look forward to, I guess, for treating heart disease in Dobermans. Sorry, as I was always saying it, I was like, no, don't say that. Don't.
Yeah, I mean, I've had cardiomyopathy, not personally, in my dogs, because I've had Dobermans for a long time. And ACE inhibitors were always the first line, and now nobody seems to be using them at all. Is there no role for them anymore?
So I think, again, the role is that when we use them, we're not seeing clinical improvement like at what I call the population level, right? So there are drugs that we give to dogs that shift the paradigm of treatment, right? Pimobendan shifted the paradigm completely. It's like every Doberman, if they have this, gets it and they will do better. You have to do it. The problem with ACE inhibitors is that at a population level, it moves the needle so little, it's hard to recommend it on every dog every time. And the way I approach it is that there are dogs who are going to benefit from ACE inhibitors. Absolutely. Do I know if it's your dog or your dog? If I'm being honest, no, I don't. And your dog may have a great improvement and it will delay their progression and they'll tolerate the drug. And your dog, it won't help them and they will get azotemic and they'll stop eating on that medication. So I tend to add it in not at the very beginning, but sort of a little bit later on. Okay, we've established what is most important in this therapeutic regime, and now I'm going to add in things that may help. There's a potential for a downside, but I think it's fine to go ahead and do it. So I think that's the way I approach it. So it's not it's only bad. And then a lot of research has been coming out looking at how much of the RAS system, so the thing that you're trying to treat, is upregulated at different stages of heart disease. And we're finding is that the RAS system is not upregulated as much as we think it is until you get to pretty far advanced into the disease, heart failure, or beyond. So I think that's why a lot of us are somewhat hesitant to just say every dog should be on it outright. And that's why we're kind of holding off on it. Yes?
I had a question, just clarification. With the type of gene, since it has some dominance, even the ones that are hetero are not doing any better than the homozygous on the type of gene that have the DCM2 gene.
Yeah, it does. I'd have to go back and look at what we found exactly, but yeah, it was, when we did the stats, we were really not breaking those two out. We were just saying if you have it at all. So it could be the homozygous dogs that are dominating that statistical analysis, because I don't think we were able to, with the amount of time that we had to put it all together, start separating each part out. So what are the individual risk factors at a heterozygous, homozygous, or multiple mutation level? But the graph looks like the heterozygous and the homozygous are similar in terms of their overall percentage of who gets it. But I do think the homozygous might be dominating that Kaplan-Meier curve.
This is even more hypothetical, but for those dogs in the United States that are homozygous normal, they don't have any of the ones, and they're still getting DCM. Just a hypothesis is that since we're not testing for 3 and 4, or just starting to test, is that possibly a factor that the ones that are still getting DCM, they're negative for DCM1 and 2
Right.
genes, BDK4 type, is that possible? Potentially, is that the RNF207 that we're just not testing for it?
Correct.
Obviously, our dogs have those genes. We just, America has not been testing for 3 or 4 at this point, so we're not trying.
Correct. Yeah, that whatever that line was, I don't know if it was blue or green. What is that? You know, like if we assume that all of this is genetic, then there are mutations that we haven't yet identified, or maybe we have identified them now due to our colleagues in the UK and in Europe, and now that we're going to apply it to our North American data set, like, is this going to start filling in the map? Are we going to finally get to a point where we can say, okay, we have 4 mutations, 2 are dominating this problem. This is what we need to focus on for the long term. Yeah. Yeah?
The question is, based on my weighing time, which you looked at,
Uh-huh.
the first echo you did on him was perfect.
Mm-hmm.
And about a year later, I did a DPN on him, and the echo said called cardio, or called DCM, so we put them on Invid and Benazir. But then, since then, the echoes that he has done are perfect. And he said if you didn't know he was on human, then you'd say you didn't have cardio. And cardio being misdiagnosed, and once they're on it, you don't take long.
Yeah, that's a great question. So, yes. Short answer is yes, it can be misdiagnosed in the sense that not every, it depends on where they are, right? Like we have cutoffs. So the cutoffs that we use when we think about the volume of the heart is 95 and 55. So if a dog is 96 and 56, we're going to say that dog is affected and should be now started on meds and things like that. So if you're hovering around there, but there are things that can cause the heart to become enlarged that maybe are not primary myocardial disease, not DCM, for example. And it could be transient. I mean, cats are notorious for doing this. They get transient diseases and then they resolve. So I would always say, like, okay, what's the thyroid status? What are these other factors that could be at play? Is there a diet factor? Is there an infectious etiology that caused inflammation of the heart and affected that? Who did the echo? What images were they using to make that? So yes, there's plenty of reasons you can misdiagnose it.
When they send them out, when a vet does an echo at the clinic, and they send it out to a cardiologist, do they send videos to
Yeah.
them? I mean, so he's actually looking at that echo?
He should be, yeah. Yeah, they have to send the videos.
Okay.
Yeah, you'd have to do that.
And if you start out, he does have, we tested thyroid, and his thyroid was low normal. But is it possible that DPS went from 1,400 and now it's at 250? Or was that such a drop that maybe it wasn't 1,400?
No, well, so there are reasons that the BNP can be elevated. So again, it's cleared by the kidneys, different metabolic issues, pulmonary issues, lots of things can actually cause it to go up. 1,500 is really high, or 1,400 is really high. So to me, 1,400 and a big heart on an echo, I think most of us would have called that. The question then becomes, why has your dog responded so favorably? And the answer is some dogs do. We do see Doberman who you put on pimobendan, whose hearts will shrink right down, and they can stay that way for 2, 3, 4 years. And then if given enough time, they will eventually start to get dilated again. So it's why this isn't always a death sentence, depending on the dog, the age, and a number of different factors. So there are 9-year-old Dobies who have DCM who are put on pimobendan and they die of something else when they're 14 or 15. Not many, but absolutely. So there's a lot of factors, and I don't know that you could ever convince me to stop that drug on your dog. You know what I mean? I'm like, no, we're not proving anything here.
But his echo has been the same the
Yeah.
last 4 years. I mean, it's just...
Yeah, and it bears that question, and I think it happens a lot, and we often question our own diagnoses and judgments, and we're like, do you have it? Did they have it? Like, what should we do about it? And the great news is, other than the impact on your pocketbook, that drug isn't going to do anything to hurt your dog, right? So at this point, we're in it for the long haul. That's how I would view it. But yeah, we can misdiagnose DCM. None of us are perfect.
Yeah, one other real quick question. The microvalve regurgitation. Is any of that idiopathic environmental cause?
So mitral valve disease, there's 2 reasons the mitral valve leaks in Dobermans. The first is they develop degeneration of the valve. So it's myxomatous, so the valve becomes thicker and then it doesn't coapt, or it can even become sort of excessively mobile. That's your cavalier, right? That's what happens to them. So the same age-related changes can occur in Dobermans. And when they get that, they usually only get a very small amount of it, and it doesn't really progress very much. The other reason the mitral valve leaks is because they have dilated cardiomyopathy, and the heart is dilating and it's pulling the tips of the leaflets apart from each other, and they develop what's known as functional regurgitation. That is usually a much more serious problem because in addition to a dilated heart, they're volume overloading it from regurgitation. And that's easy to differentiate because one dog has DCM and the other one does not.
Well, the echo, when it showed the regurgitation, and that's the same dog.
Yep.
So his heart is normal size, you know, it's not enlarged or anything, but he's got that regurgitation. Is that from cardio, or is that just he's a 9-year-old dog?
I would say it's because he's a 9-year-old dog.
Well, and then my 7-year-old that you did, her echo is perfect. Now, her BPM has been at 200 forever, and it started to rise like 470.
It goes up with age. It is there. We have to get enough Doberman to really create true reference values for. But we know in dogs in general that the NT-proBNP goes up with age. So the how much does it go up, and what do those trends mean? And so again, you know, we've done a lot of work with cats, and one of the things that we found in cats with hypertrophic cardiomyopathy or screening is that NT-proBNP in a cat has to at least double in order for it to represent a true change in something that's happening in the heart. So doubling in a cat, you know, when the value is 50, it has to go to 100, and that's like big deal in a cat. 100's a big deal. In dogs, right, we're going much higher numbers. So if that were true, if Dobermans were like cats, then the value that the baseline would have to more than double or potentially triple in order for us to say, yeah, this I think is a real change and not just creeping up with age and all the comorbidities that come with being 7, 8, and 9 years old as a Doberman.
Now, do you recommend your echo, your BPN, and your halter, all 3 tests every year?
I wouldn't recommend doing the NT-proBNP unless you weren't going to move forward with the echo, right? So if you're going to get an echo, that's better than an NT-proBNP. It's going to tell you exactly what's going on. If you were trying to decide, should I do an echo this year? Is it important? I've had 7 normal echoes. I would say do the blood test, right? If it's 250, I reasonably think you're fine. Go ahead and just do the Holter, because the NT-proBNP can't determine arrhythmias. So dogs can have really bad arrhythmias and normal BNP, so you still have to do the Holter part. But if the BNP is normal or very low, and somebody wanted to skip a year, I'd be like, yeah, that's totally reasonable. That's totally reasonable. You know, I think most breeders, though, and most owners are getting the echo, so they don't need to do the test. I think I use the example of you've got 14 Doberman, and you're trying to figure out which 7 are going in the trailer this year. Like, that's a pretty easy way to do it. Some people are like, which ones do I like? Which ones are going to wreak havoc? But also, you know, if you're trying to be more strategic, that can be a really helpful tool to do it. Although, if you're sending them out to IDEX, it's basically the same cost as doing an echo here these days. Like, I think IDEX is going to charge like $100 and something for it, and then your vet's going to charge you on top of that and ship it. It ends up being close to like $180, $200 now to do them. They're really expensive, which is why we just bought the analyzer ourselves and do it in our clinic, because the analyzer was $1,500, but each cartridge is $10. So we're able to, you know, do a BNP on a Doberman for an owner for $25. So, yeah. Yeah.
Do you know of any new medication or drugs that potentially be coming out to help our DCM dogs?
I think Entresto is going to be the drug that people are going to start looking at a lot more closely. So Entresto is a really cool drug. It's a combination of 2 drugs. One is an angiotensin receptor blocker, and so that's a drug called valsartan. And then it's another drug that's a neprilysin inhibitor called sacubitril. And neprilysin is the enzyme that breaks down BNP in the body. So BNP is not just an inert thing that we test for in the blood. BNP is metabolically very active. And what it does is it causes the body to get rid of excessive water. It helps vasodilate the blood vessels to keep blood moving forward, and it helps protect and slow down remodeling of the heart. And in people who take Entresto, they feel so good. It makes them feel amazing, and it's really one of the only medical managements that has actually been proven to increase survival. And so we were just saying how, you know, that drug has been proprietary, and we've had a handful of dogs on it, but most owners couldn't afford to do it. You know, it was going to be about $2,000 a month for a Doberman, but now it's going to be $65. So I think that is going to be heavily evaluated in the
What
future.
about rapamycin?
So we did a pilot study looking at rapamycin in DCM. It wasn't just Dobermans, it was all dogs. And the overall statistic didn't show significant delay in progression for the whole population, but there were individual dogs who were receiving the low-dose rapamycin who did have some improvements or a slower progression. And so we've given all that data back to DCVIM, the company, and they're trying to figure out what they want to do with that, if they want to roll out a pivotal trial to sort of look at it in all DCM dogs. So the ball's in their court. But
I had a dog, I worked with Dr. Gordon, was in the trial with him.
Yeah.
And we stayed in it for 2.5 years.
Yep.
And he stayed, he didn't progress any further. And then all of a sudden they cut off the drug, and I hate to say it, I lost him within a month. It seemed like his body needed it after being on it so long.
Yeah, we have a lot to learn about rapamycin. It's a really cool drug. I want that. I wonder if it's going to be very individualized in dogs, like some dogs, because in our trial, you know, we did, like Sonia did it in Texas, we did it up in Illinois. We didn't have any dogs that had like dramatic improvements, but we did have dogs who just were kind of status quo. They didn't really progress very much, which DCM is progressive. Almost every dog is going to continue to progress over, it was a short study, right? 6 months.
We stayed in for 2 years.
Yeah, but I'm saying is you were able to.
She said it doesn't hurt, I have the drug.
Correct.
You know, come get the blood, make sure there's no, you know, nothing else happening with liver or anything, and I did. And then, I mean, she documented him for 2.5 years for the company, you know, and he did stay just normal. You know?
Yeah, I mean, it's on our list, right? We have to.
When he didn't have any more, guess what? It just.
Yeah. Yeah, well, the whole aging and the mTOR pathway and all of that it's beyond my full comprehension of how drugs work, but I know that there's a lot of interest in rapamycin in the cardiomyopathies to see if there is some value in that. But yeah, stay tuned for that.
I wanted to see what I knew you were.
We're still, Sonia and I talked to Stuart and the group at DCVIM at ACVIM in June. They're very excited. They want to do something, but right now all of their life is consumed by looking at rapamycin in cats with HCM. They are like all in on that right now. So I think we're kind of in the waiting room. Hopeful. Yeah.
So when Entresto becomes more readily available, what are going to be the recommendations on who gets started on it? What criteria?
I think it's going to be veterinary, like cardiology dependent, right? So right now, the most common indication that people are using for Entresto, because again, we were really limited to small dogs. Like it just was prohibitive. So most of us are using it at the onset of heart failure in dogs with valve disease. So that's when we were using it. That's what the indication was in people to start it in heart failure. What we have come to see is that it works really well. Dogs tolerate it really well. And we have been sort of inching it backwards incrementally. So now some dogs who have valve disease, right, and valve disease and DCM share some commonalities. We start them on pemobendin in the preclinical stages. And then what we found is that some dogs who are preclinical valve disease dogs, their hearts will start getting really big really fast, and we'll start them on Entresto. So I think the first step would be probably the heart failure group, and then start incrementally working its way back. And I think there is some potential that it could end up being on that list with the preclinical stages of the disease. But it's a huge dose. It's like 20 to 30 mg per kg. So, I mean, it's a massive dose of this drug. And the highest dose, I think the highest tablet size that they come in is around 200 milligrams. So it's going to be like 5 pills twice a day, which is why I said before, like no one could afford it. It was thousands of dollars. So, but I think that there's a lot of interest in it.